Hi, this is Dr. Paul from the Dr. Paul Show. Today I'm going to talk about the neurochemicals that I deal with. Before I get into it though, please press like and subscribe so you can stay up to date with the current content. So if you've watched my show and you've seen the drawings I've done on my whiteboard, I try to simplify with patients. So every patient I see, I draw diagrams of neurons, I explain what medications are doing. So basically, to try to keep it as simple as possible, the nervous system is composed of a lot of nerve cells constantly communicating. Chemicals are traveling around the system about 1,000 times a second. There's over 100 billion nerve cells in the body we call neurons. There's over 100 trillion connections we call synapses, the connections between the cells. There's a lot going on, obviously. The problem that comes is when the chemicals are traveling from one cell to the next, they're supposed to be going one way, not the other way. They're supposed to be going forward, not backwards. And sometimes there's certain ones that go too far forward, too far, and they have to slow down. We'll talk about that in a moment. So the problem becomes that certain people develop leaks on the cell membrane, so the certain chemicals start to leak, and so the chemicals that's supposed to be going just forward start to go backward. So this is where the term neurochemical imbalances come in. The chemicals go out of whack. Why does it happen? Again, I've talked about it before, genetic reasons, hormonal reasons, stressors, trauma. So some things happen that causes a disruption of the nervous system, causes the chemicals to go off track. I simplify it into 4 chemicals. There's more going on. There's a lot going on. There's a lot of chemicals. I like to simplify it down to 4 chemicals: serotonin, norepinephrine, dopamine, and GABA. With GABA, there's also a chemical called glutamate. So most people have heard of serotonin and with the medication called SSRIs. So serotonin, I'm going to try to simplify things. It's not always as simple, but symptoms that have to do with the serotonin imbalance would be, well, depression, anxiety, obsessive thinking like OCD, worrying. Let's see. Sometimes if a woman has premenstrual symptoms, some people know it as PMS. It's actually more appropriately called PMDD. Sometimes certain sexual problems have to do with serotonin. So when I get a history from patient, I'm taking note of every symptom the person has, and when I'm doing that, I'm trying to figure out, when I look at all the symptoms, like trying to figure out, okay, what neurochemicals are probably involved here. Norepinephrine is a second one. What's with that involved with? It's with anxiety, with depression. But with norepinephrine, it also involves the physical symptoms. So pain, like I call somatic symptoms. Somatic symptoms mean painful or physical symptoms like headaches. And then the most common we're going to see is, and people can relate, the like neck and shoulder, because when people get stressed, they feel like, can you give me a massage? Most massage therapists spend most of their time in the upper back area, because that's where most people store their tension, at these muscles. Also the head, the headaches. Where else? Stomach aches, irritable bowel syndrome. When people are under stress, they get chest tightness, they get sweating, they get shaky, they get nauseous, their heart is racing. So norepinephrine, serotonin with anxiety, but norepinephrine even more symptoms of anxiety, and then the somatic symptoms, like I said. Dopamine. Now, with dopamine, it can either be going too slow or going too fast. So it's leaking the wrong way. And if it's going the wrong way, then you're going to have symptoms of low motivation, low energy, depressed mood, lack of joy, lack of pleasure. So people who are just feeling apathetic and just don't want to do things, they don't want to go out, they just want to stay at home. these are people who have probably, we call it dopamine deficiency. But with that, isn't there? And again, you got to remember with these chemicals, there's not a deficiency of the chemicals. That's a misnomer. So when people say, oh, I'm serotonin deficient, I'm dopamine deficient, they're not deficient. That means the chemicals are imbalanced. So if they're going, so basically, if it's going the wrong way, you're going to see that. If it's going too fast, you're going to see. That's where we're going to see symptoms of bipolar disorder, like racing mind, paranoia, sometimes insomnia, irrational thinking and behaviors. So those are like bipolar symptoms. GABA, what happens when GABA is imbalanced? You're going to see anxiety, you're going to see pain, like also we call somatic symptoms. So somatic symptoms, when I hear that, when I hear of physical symptoms and like headaches and other symptoms, I think either norepinephrine first, and then I think about GABA second. But those are the two main ones I think about when I think about physical symptoms, which is something, if you know anything about my books, and my first 3 books is all about this whole mind-body connection and what that means. So when GABA, when we get GABA going the wrong way and it starts going the right way, it relaxes the person. It reduces anxiety, it reduces pain. That's when GABA, and see, GABA and glutamate are opposites. So when GABA is going this way, glutamate's going that way. When glutamate's going this way too much, you're going to again see fatigue, lack of motivation. And when glutamate goes the right way, you're going to see increased energy and motivation also, just like with dopamine a little bit. It's hard to simplify it, like I said, because there's different symptoms for different. It might be different for different people. So what do we do about serotonin? So serotonin, if I believe it's a primary serotonin problem, this is where the term SSRI, this is the medication class, which stands for selective serotonin reuptake inhibitor. So think about that. It's inhibiting the reuptake of serotonin. So what it's doing, it's attaching to that site. It's basically fixing the leak. I call myself a plumber because I just fix leaks all day. So when you fix a leak on that serotonin site, it forces serotonin to go the right way. I do use SSRIs, not as much as a lot of other doctors, because I don't think they're the first line agents like many doctors do. The problem with the SSRIs work, and they definitely help, but the problem with people with them, and some people can relate to this if they've been on them, they make people feel kind of apathetic, kind of flat, kind of eh. But some people say, well, at least I'm not anxious, and at least I'm not as depressed. Yeah, but it's better than okay. What that means is either we need to add Wellbutrin, we'll get to that in a moment, or it means we need to switch it to something else. I'm a big advocate of SNRIs. You know, I've thought for over 30 years when Effexor XR came out, then really, if you go back to my history and read my new book and read my old books, that's what really, I started really getting more interested in this in the early 1990s. Like within a year of starting practice, I started to understand that this was different, this medication, because I started seeing people's pain going away, and I started seeing their anxiety getting better, and I started seeing better results than SSRIs. And I knew it had to be norepinephrine. And so I started prescribing those a lot more and getting better results and more complete results. And then again, SNRIs, serotonin, norepinephrine reuptake inhibitors. Again, inhibiting reuptake. So it works on serotonin, norepinephrine. And if you see my drawings, I explain that. And so now we got 2 going. So let's say that's enough. That could be. What happens though, a lot of times I'll add Wellbutrin. Now Wellbutrin is an NDRI. So that means a norepinephrine and dopamine reuptake inhibitor. So what that does, it doesn't work that much on norepinephrine like the SNRIs do, but it works more on dopamine. So when you do that, when you fix that, motivation, energy, normally Wellbutrin is not by itself. I normally add it to an SNRI or an SSRI, especially when one of those two helps the mood, helps the anxiety, but there's still residual depression, there's still lack of motivation, energy. then when I call SNRI Wellbutrin, I call the dynamic duo of medication because it's the best combination I've ever worked with. It's probably the #1 combination I prescribe in my practice too. It's not for everybody, but when it works, it's amazing. Again, when dopamine is going too fast, then we use what I call the atypical antipsychotic agents, and these are what we call dopamine antagonists. So, dopamine antagonist means it's slowing it down, and it also slows down serotonin. They're also serotonin antagonists because with bipolar disorder, we need to slow things down. And even if serotonin is sometimes an SSRI will make bipolar patients worse because, and sometimes any antidepressant will with some people, because we need to calm things down, not speed things up. So, but again, in the term antipsychotic is kind of, it's not necessarily, because most of the patients I see who I treat with these class are not psychotic. And they're at all. We use it for that, but we also use it for, we call treatment-resistant depression. We use it for people who just are not at full remission with antidepressants by themselves. They're an invaluable class of medications. There's a bunch of them out there: Rexulti, Vraylar, Seroquel, Abilify. I can go on and on. There's a multitude of them out there. Now we move on to GABA. So with GABA, when we need to get that moving the right way, which actually calms the system, we have Topamax, which is an amazing medication. It helps with anxiety, it helps with pain, and it helps with weight loss because with Topamax, it actually reduces the desire for sugars and carbohydrates. So I usually dose that in the early evening because most people binge on foods like that in the evening. And so it helps them lose weight. It helps take away the cravings. And so, it's a medication I've been working with for over 30 years. It's been approved for migraine headache prevention for many years. So that's an example right there of a pain condition that it works on. Well, it not only works on migraines, it also works on a lot of other pain conditions. So Topamax and gabapentin is very good. So a lot of people heard of gabapentin. They take it for pain. They take it for anxiety. A lot of neurologists use it. A lot of pain specialists use it. It doesn't have the weight loss benefits of Topamax, but it's a very good medication. Depakote it works on GABA. There's a very exciting medication now out called Auvelity. It's the only new antidepressant that's been out for many years. It's the newest antidepressant is Trintellix. But this is an exciting medication, and what it is basically it's Wellbutrin is part of it, but it's also it has a component that boosts glutamate. So when you boost glutamate, it's not the calming effect of GABA. It's the we call excited effect. It's a stimulating effect. So it really is very good for people who have depression that's not getting better with other medications. If I put someone on Wellbutrin, I'm not getting that robust effect that Wellbutrin normally gives. If it just gives partial results, then sometimes Auvelity is a really great product. It's expensive, so you have to get it approved on your people's insurance, but it's a really exciting new medication. So I think that pretty much covers the neurochemical imbalances. I can go further into it, but I think that's pretty much is the basis of it. If you like what you've heard and if you'd like to share this, I'd love it if you could share this with other people who might be interested in this topic. And if you have any questions and comments, please send them my way. I'll answer every one of them. And thank you for listening.